Today's lecture is the outcome of a virtual exchange project between the University of Florida and the Universidad San Francisco de Quito. And on Monday, actually, the UF students and the University of San Francisco de Quito students met virtually to discuss about different topics around COVID and to share their own experience, and they really enjoy. So that was like the very beginning of this project. And today, Professor Palacios will give a lecture about COVID-19 in Ecuador, interventions, lessons, and impacts of the pandemic. This lecture will become part of, it will be like a special lecture, and it will become part of our course about the circular nature of COVID-19 that the One Health Center is offering this semester. And I want to actually, before I introduce our special guest, I wanted to announce that we will offer this course next semester as well. So if you want to know anything about it, please contact either me or Rania. And we were able to start this project thanks to the Global Learning Institute. So if you wanted to know more about virtual exchange projects, please contact Paloma Rodriguez. I don't know, Paloma, if you wanted to say anything about it, but I added here the website and your email. So I'm sure that if you wanted to know more about it, like, please feel free to contact Paloma.
Just to say that what you are doing is an innovation on global learning, and I want to congratulate all of you for engaging students in this collaboration.
Thank you, Paloma, for giving us this opportunity, which has been quite timely considering the situation that we are living now. I think now I can stop sharing, and I can actually copy and paste our contacts in the chat, so we are sure that you all have it. And I think, Rania, shall I introduce our speaker now? So today, again, like we have Professor Palacios. Professor Palacios received his medical doctoral degree from the Universidad Central in Quito. And he also has a master in public administration from the University of New Mexico. He has more than 20 years of experience working in the design, implementation, and supervision of public health and social development projects. Professor Palacios currently is a professor in the School of Medicine and the Director of Educational Activities in the affiliate hospital, Hospital de los Valles. And thank you so much for bringing your students on Monday. I think that was quite a successful event. And thank you for providing your insights today. So the floor is yours whenever you like. Thank you.
Thank you very much. I would like to start thanking Rania, you, and Paloma for inviting us to be part of this interesting experience and learning experience for all of us. I think COVID is giving new challenges, and I think we are taking advantage of the technology to learn one each other and share experiences. So I really appreciate it, and we at Universidad San Francisco de Quito are always trying to enhance our partnerships, and this is part of also our global health initiative in Ecuador. So I'm glad that we have the opportunity to share some lessons learned that we have been able to achieve during this pandemic time. So Rania, if you are so kind to start with my presentation. Should I share my screen? Is that?
Please, yeah, we just,
yes,
yep,
please.
Thank you.
There you go.
Yeah, sorry, I share mine, so I took yours for a moment off. Thank you.
Can you see my screen? Thank you very much. What I would like to address today is to talk about the pandemic in Ecuador. You know, what has been the extent of the situation in the country, and how is the pandemic has affected different parts of the country, what has been the interventions implemented by the government, by the Ministry of Health and other institutions, as well what we have done. See if we can share some lessons and discuss about the impacts of the pandemic. So before I start, I would like to start introducing where is Ecuador. Ecuador is located in America, in South America. It's located, has borders with Colombia and Peru. And we also have a part located in the islands, which is Galapagos Islands, that are famous for the biodiversity, and many of you probably know or are planning to visit. This picture is trying to reflect some characteristics of the country. Here we have Mitad del Mundo, which is located north from Quito, 30 minutes if you drive. And this is basically reflecting that we have three very clear regions, and each region, geographical region, has a climate and some cultural aspects. So every time when we are talking about Ecuador, what I wanted to say is a biodiverse and different cultures. So social determinants of health, economic development are different. So in the highlands, which is basically the picture that is reflecting the Mitad del Mundo, we have more people that it's considered mestizo population, and indigenous groups are located in this area. Where in the east area of the country, we have the rainforest area and oil companies, and in the coast we have other type of population, and the last picture is related with Galapagos. So what I wanted to say is each region has their own context and environment, economical development, cultural aspects, education, and so on and so forth. The population of Ecuador, it's 17 million people. This is data coming from the National Census Institute. And it's important to know the distribution in terms of ethnicity, the different ethnic groups that are in Ecuador. This information is coming from the national census conducted back in 2010. When they visited every home, they asked people, how do you consider yourself? So it's not about somebody saying you are considered indigenous or white or mestizo or whatever. So 70% of our population is considered mestizo, which is a mixed heritage from Hispanic and indigenous population. Around 7% of the population is indigenous and living in the central part of the country, is in the highlands especially. Montubio, it's another mixed group of population. It's located in the coast area of Ecuador. And we have a very focused group of population located in the north west of our country. It's Afro-Ecuadorian population, and only 6% of the population is considered white. The most largest population of indigenous are located in Chimborazo, Pichincha, and Imbabura. These are the names of the provinces, which it's like the states if you compare with America. So we are located in the province of Pichincha, which is the capital of the province is Quito, and as well the capital of the country. And in Imbabura, we have a lady in this picture that it's a typical picture of typical outfits of people that lives in Chimborazo. And many times when we discuss about the social determinants of health, I use this picture in my class with the students. Say this picture says a lot. When you are talking about disparities and you are talking about equity, this picture is reflecting the inequity. Women, rural, and indigenous. So they are the most affected groups, and they so when we are talking about maternal mortality, child mortality, we are talking about this group of population. Unfortunately, this picture reflects the inequities. Here are some indicators. I am contrasting with the USA, the population, the percentage of population under 15 as 30, which means Ecuador is in a transition. We are transitioning from a young group of country population and beginning to start aging. And so we are facing problems related with underdeveloped typical health problems, which is child and maternal health problems. And the other side, we are beginning to see problems related with chronic non-communicable diseases and as well aging-related health issues. So 7% of the population is considered above 60, and probably we will see within the next 20 years going very quickly to 15% of the population. That's our projection. So we in South America tend to do everything very fast, as Italy and other countries where aging process was very, took years to transition. And in South America, we are transitioning very quickly. We are becoming a urban also population, moving from 50% back in the 60s to 63% right now. And in terms of fertility, we are doing, good family planning and moving from 20 years ago, children per woman to 2.6. Of course, this is an average, it's a national. So if you go to indigenous communities, probably still is high. Life expectancy is increasing. At least it was before the outbreak. So many of this data, it's not updated. I was looking for updated information. It's probably going to be difficult to get what's going on right now. And in terms of health determinants, what I wanted to say is before the outbreak, 25% of the population was considered living in poverty, making more than $2 a day, and 5% on street poverty, probably making just $1 a day. So people are saying that we have changed because we made important advances on this regard, and probably 35% of the population is living in poverty. That's what World Bank and other entities are saying, due to the outbreak in Ecuador. And this is another problem related when we talk about the social determinants of health, gender disparities. Women were not making the same amount of money of men, and of course, indigenous women, if you compare it with mestizo women, were making also less money. This is again before the outbreak. In terms of education, 7% of the population over 15 years old is considered illiterated, especially located in the rural areas. And when we talk about this type of problems, education is very important when we talk about COVID and public health implications. So in terms of nutrition, it's another public health problem that's probably going to be increased. About 25% of the population suffer from malnutrition, and 4% on obesity and overweight, moving from 4 to 8% more or less. And it's one of the largest public health problems. We had moved from 40% in 1998 to 25% these days. And many policies and programs has been implemented, and yet we haven't been able to solve this public health problem. terms of access to water and sanitation, 77% of people has connection to water. And this is important when we talk about the outbreak. One of the strategies was to use water and wash your hands. So many times when we talk about this in Guayaquil, some neighborhoods in one of the largest cities in Ecuador didn't have access to water. So this is one of the reasons probably many people in that city was affected. In terms of fertility, we are still struggling with family planning, even though many advances has been made on this regard. And this is also, I just used this to compare many people, and we are complaining about the access to family planning for women, and especially for adolescent population during the outbreak. It says that many people didn't have access to drugs just because they were concerned and didn't go to the clinics to get treatment just because they were afraid to get, COVID. And also the other is the supply channel from the Ministry of Health to the clinics located especially in some isolated areas. Family planning was 80%. As again, this was before the. Sorry, I made something wrong. So I was talking about family planning, and it was before the outbreak. I think the numbers has going down a lot because we are expecting that pregnancy has occurred because they have lack access to family planning methods. When it was because they were afraid of going to the clinic to get the treatment, or the logistics, the provision from the Ministry of Health to the clinics, especially to those located in rural settings. Prenatal care, 95% of women, and we were struggling with having at least 5 prenatal checkups during pregnancy. In the district area where we are working as a School of Medicine with the Ministry of Health, the average is 3.5, prenatal controls. It was before the outbreak, and I think it's going down to 1.5 or 2. Women are starting going back to the clinics. They are still very concerned about this. So we don't know how this is going to affect maternal health. Cesarean deliveries was 41%, very high. World Health Organization is recommending not to be more than 15% of all the whole pregnancies. Postnatal care, mammography, PAPS test, probably all of these numbers has been going to be affected, and we need to work very hard to see how are we going to go back to where we were before. In terms of children's health, on a yearly, during the first year, it's recommended at least to have one control on a healthy child per month. So the numbers as well, it was not bad, 47% during the first month. Probably now it's less than 20%. Probably prevalence of diarrhea diseases has been going down as well. This is a good part because many people are washing their hands just because the outbreak, and probably this is going to affect positively on the prevalence of diarrhea. I'm going to start moving. Infant mortality, there was indicators related with this group of population before the outbreak. One of the biggest problems we were facing is teenager pregnancy. And we as a university have been working, I have, some project related with the health prevention, teenager pregnancy prevention programs. We were planning to start a study related with male role on the teenager pregnancy in order to start focusing and targeting also interventions to this group of population. And I was reading a report that was open a week ago, and they are expecting that at least now it's 40% of pregnancies because they didn't have access to family planning methods, and that's something that is going to also be one of the outcomes of the impacts of the outbreak. So how we are organized in terms of service provision. We have a fractionated, not probably as in the States. We have a mixed system in Ecuador that one is provided through insurance company, public and private, and the other is universal coverage. This is provided by the Ministry of Health. It's still a hospital-centered approach, even though during the last decade, many efforts has been made to move to the primary healthcare settings and to the clinics to start implementing prevention and promotion. Better health services are provided in big cities, and rural areas are neglected, lack of understanding some cultural aspects, especially indigenous. And this is our constitution. They're saying, our constitution is saying that it should be provided health services through the public state health services, free of charge, and provide all of this, And when we had 10 years ago a very important income through the oil selling, we had the commodities gave us a lot of money, and we were using to enhance the health system. But now the government is broken, So we are seeing that this is not going to be feasible to complete, and how we are going to finance all of the services that are part of the Constitution is something that we are starting debating. So in terms of health providers, the Ministry of Health is covering around 40-41% of the population through the network of clinics located from primary healthcare, secondary level, and tertiary, which is specialized services. Private providers, especially directly, 28% of the population. And Social Security in Ecuador, the Social Security difference with the United States, Social Security also has the network of health providers in Ecuador. So 31% of the population is covered by the clinics that are managed by the Social Security. And Social Security is offering services for people like me who are, working in an institution, and we, is discounted from our salary. 11% of our salary goes to cover those services on a monthly basis, and the employer also cover cost of that prime. And the Ministry of Health is covering the cost and funding this through taxes and commodities. So the system from the Ministry of Health has the first level, the second level, and the third level. And the first level, the idea is to provide services to the family, to the community, provide services and promotion, prevention, and treatment. And if they cannot solve, refer to the second level. And if they cannot, to the specialized level, which is located in the third level. This is what we are trying to move, and the government is trying to invest a lot in the primary healthcare clinics. And so in terms of COVID, I'm trying to now beginning to share information. We began, the first case was reported back on February 29, and on March 16, it was declared the state of the exception. And this is more or less the main, restrictions that was, declared by the government. Public services are closed except health, safety, services, and so on and so forth. The ministries are open just services that are part related with the emergency. Ministry of Education is closed, and other ministries are closed, and just open markets, and neighborhood stores were open, and for a certain period of time, from 6 a.m. to 2 p.m. at the beginning of the exception, which was 2 months, March and April. And then they moved from 8 a.m. to 5 p.m. and then later on from 5 a.m. to 11 p.m. So now it's more or less this is how it is working. Of course, hospitals, clinics, and private providers were, has the mandate to be operating and open to provide services, and digital home platforms are being used to telework. Many people in different sectors were doing telework at least until September. And now some are beginning to open and start having part-time people coming to do their job. Public transportation is also reopening, and they open at the beginning 25%, then 50%. Now it's 50 to 75% of the public transportation. And this is the curve of how the pandemic has been affected the whole country. This information is coming from the the Ministry of Health. It's public information. And then we have Guayas, which is Guayaquil is the main city located in this area. And there was really one that was very much affected at the beginning of the pandemic. They began on March through April receiving a lot of cases. And if you compare with Quito and Pichincha, we began probably on June, and the numbers were starting going up and up and up. And this is very important because in Guayaquil, we were discussing that probably we began the close of the city too late. Many people are saying it should be done on February, or January, to start planning and providing services and educating. And this is an interesting curve. They began in February or March and ended on April. And you're saying most of the people were infected. They're saying about 40 or 60% of the population. And now they start seeing some, cases in the city. And it was good because in Quito and the rest of the country, due to the pandemic in Guayaquil and seeing people dead, corpses on the streets, and people having no access to the clinics and intensive care units full of services and many patients, they opened new beds and organized new services, especially intensive care services, quickly. Everybody were afraid of this is going to happen nationwide. And so local authorities start beginning preparedness plan, organizing clinics, increasing the numbers of ICU services, and so on and so forth. So in Quito, we talk about June when they opened the city, we start seeing the cases. It wasn't as it was presented in Guayaquil with high numbers and many people affected. We are still seeing some cases, and the mortality rate, it was totally different with Guayaquil. We were able to get prepared. Government didn't have the preparedness when the outbreak started. So we were not testing enough. We didn't have, ventilators. We didn't have masks. All of this safety equipment needed, and PCR tests and everything. So this early beginning helped, our country to get organized and get better prepared to respond in other communities than Guayaquil. And I think even though we have some troubles. The lethality, the mortality has not been very high. This is Pichincha, where we are located. This is reported, this information was on October, the last information. And this is how the pandemic has been affecting, taking the city of Pichincha. And we are expecting that the numbers are going down. Last week, I am a member of a local advisory group. The city invited us to be part of the advisory group. We meet on a weekly basis. And last week, during our meeting, they said that was the first time they reported that 2 beds from intensive care units were available for patients. Before that week, we didn't have a full occupation of beds, and during June, July, August, and September, and the beginning of October. So we are seeing the numbers are going down in terms of use of intensive care unit, but the numbers are still going up and up and up. This is the coverage during PCR testing nationwide. One is reflecting during last 4 weeks, the PCR testing that is being conducted. And the other on green is the cumulative testing that is being conducted in Ecuador. And this has been very low. And even though now we are beginning to increase the number of people that is being tested, we haven't been able to achieve the numbers recommended by the World Health Organization. Patients with isolation, only 70% around that is being isolated, and 31 hasn't been isolated. And this is also very critical. If you are identifying and giving this information on time, that patient is positive, they can be isolated. So the complaint here is because the system is not providing the information quickly. So it takes 4 days or sometimes 1 week to get reported. But during that period of time, even though you are informed that you probably are positive, many times you are still working, you are, contaminating and not having enough protection. And this is why probably we are still seeing the numbers going up and up and up. And tracing contacts, we have been able to increase from August. Only 22% of people were, that we were able to trace some contact. And we are moving in September to October to 42%. And we, as part of the university, are doing something. And later on, I'm going to talk about how we are part of the response as well. So in terms of doing an analysis of how are we doing at a national level, what I did is I used the WHO Strategic Preparedness Plan design, where they define in these categories. They launched this draft on February. They have made some changes, but they are recommending to have, country level national coordination entity in charge of coordinating, planning, and doing monitoring of the outbreak advance, risk communication and community engagement plan, having surveillance. So what I did is I put on green what I consider has been the things that we've been doing more or less fine. On red, those things that we haven't been able to conduct, in a proper manner, and on yellow, those that are moving from red to green, using our lights to make it simple. It's not a study. It's based on the meetings that we have on a weekly basis, how we are seeing the country is doing. So surveillance, rapid response teams, and case investigation, especially that piece, it's been weak in nationwide, especially in some rural areas, especially in some provinces that they have isolated population. Points of entry means airports, how this is being controlled. Airports were closed, we just reopened 2 months ago, and people were asked to be tested before you enter to the airplane, and so on and so forth. The risk communication plan was good every day on a daily basis. It was a national, information regarding the numbers, how this is being affected, and especially the strategies, washing hands, mask utilization, and social distancing, and staying home as much as people can. I think national labs it's something that it's still struggling in our country in terms of provision of services to test and report on a timely manner to make sure the system can especially isolate those positive cases and manage properly. And again, infection prevention and control is also something that needs to be improved. This is doing some surveillance at the community level and contact people that it's been in contact with positive people to test and isolate if the case. The case management, it's in some cases it's been good, in some cases is not, still needs to be improved. And operational support and logistics can be from red to yellow. Corruption, it was a shame, people in the middle of the crisis on March and February, some hospitals and some people that was in charge of buying, tests and protection and drugs were fined on corruption, and they were, some of them are in jail, and it was this really affected, and how this affected is we are working with chronic non-communicable patients, and for a month or something like that, they didn't have access to medical treatment for the hypertension and so on and so forth. So I was using, the position I had on this advisory group to inform to the policymakers and say, hey guys, we are trying to keep our people that is affected with diabetics and hypertension at home, and they cannot be home because they have no treatment. And what are we doing? So a month ago, they solved the problem, and that's it. So this is a picture of our main campus at USFQ. And now I'm going to talk about what we have done, because many times when we are talking about outbreak, we are using the comfort of sharing and attacking or analyzing data. And that's a very, nice position. But, from our side, we say, no, we have to do something. And so on March, as early as March, when I learned that COVID is going to affect especially people with diabetics and hypertension, I designed a telehealth project, which is implemented until today. And it's not telemedicine. It's because I involved students from the third year of the School of Medicine, and they are not allowed to provide medication. So it's telehealth, and the objective of this project was to support people in the rural communities where we are normally working, 16 communities that we usually work with, support in terms of prevention and promotion. We focus our intervention on during quarantine period on elderly and chronic non-communicable patients, and later on with adolescent population, pregnant women. The idea was to check up people, how are they doing in terms of their disease, whether they have treatment, whether they are, the other ends of the treatment, the nutrition, exercise, psychological status of these people, and also providing advice about the management of COVID, washing hands, staying home, wearing masks, if they have access to alcohol, use alcohol and staying home, social distance as much as they can. Also advice of nutrition and also provide emotional support. When we began, we started with 70 students, and now we have around 140 students from School of Medicine, Psychology, Nutrition, and Microbiology, and also faculty from these schools are part of this project to reinforce, educational messages, promote prenatal control with pregnant women, work with adolescents. How are we doing this? We've been working for 5 years. I designed a project called, which is part of our community engagement plan. And on a weekly basis, third-year students go one day from 8 to 4:30 p.m. to the clinic and learn about vaccines, pregnancy, and are part of prevention and promotion activities at the clinics. So after the outbreak started, we are not allowed to bring our students to do that. But we have an agreement with the Ministry of Health, and we say, why don't we help you? So they gave us the information of patients. We designed a training program for our students. I spent 3 weeks training them using Zoom conferences, doing like they are calling a patient, what's the message, how are they going to manage some concerns they have, and all of that. So we also asked the students to sign a letter of confidentiality in which they are responsible of managing properly this information, not sharing this information with anybody. So, and later on, we were able to get some funding from Penn State University, and they gave us money to buy face shields. So we were able, through the clinics, to give to the patients that are living in the rural area, that is part of our program. And this is one of the clinics, primary health clinic, and we also give face shields to our staff, medical staff from the Ministry of Health. And this is for people who are patients, and we know they cannot stay home doing telehealth because they need to maintain their homes, their families. So we were also giving these people these face shields to double protect them and provide education about this. So we collected data, and they are part of the program. They are receiving phone calls to reinforce the importance of washing hands, wearing masks, and wearing the face shields. So achievements, there's 2,000 face shields were provided to people from the rural communities, especially elderly and chronic non-communicable patients. We have been able to attend 2,000 phone calls, 450 physical support, nutrition, medicine, and also we were able to provide PCR free of charge. Those PCRs are conducted from our lab of microbiology, 1,500. As I said, we are members of the advisory group of the city, and also we are part of the Solidarity vaccine. 3 faculty are participating on this program. I am one of them. We are expecting to be part of this research, and we participate on a weekly basis, twice on the meetings organized by the World Health Organization that is planning to implement this study. So I'm going to stop here and probably say that one of the outcomes of this pandemic is also that it's positive. People are start using bicycles to transport, and a lot of demand. It's increasing in terms of bicycles. So I'm going to open the floor for questions, comments, clarifications.
Thank you very much. That was excellent, and what a great idea. I'm going to share the way that you folks can ask questions. So I'm going to grab the screen here. Okay, so if anyone would like to ask questions, you go to this website, www.menti.com, and you enter that code and ask your question, and it'll pop up on my end, and I'll ask them for you all. Thank you again. While people are typing their questions, was the reception very good from the population with these students making these calls? Did you get a lot of positive feedback from the population?
Yeah, I've been calling, the population to do what's going on. Fortunately, every single call was, the students say, hello, good morning, my name is so-and-so. I am calling from the clinic of Belkinche. La doctora X is asking me to give you a call. So that was the connection with the clinic. And then, oh, yeah, okay. So the doctor is asking me if you are doing okay with your health, how are you doing with your drugs, and so on and so forth. The people were very friendly. Many times, people ask for a follow-up and conversations, and that's why we incorporate also psychological, psychology school to be part, because some of them, when our students were trained to identify depression, were referred to them. So our student was saying, I'm going to give to my colleague that is on the psychology school to give you a call and see if you could, are you agree? And they say, yes, of course. So yeah, the problem was many times the numbers provided by the clinic were not accurate. Many people in the rural area, they buy the cheap $5, and when they, and that period of use ends, they don't realize that they can use the same number and recharge their phone. They buy a new one. So in some cases, that was the situation.
Mm-hmm. Thank you. We have another question. Can you talk a little bit more about how you decided who to distribute masks to, given your limited supply?
What we did is we asked to the 16 clinics. We are working with 16 clinics managed by the Ministry of Health, and they are also tutors of our School of Medicine. So we have a very strong relationship with them. And I said, well, we have 2,000. There are 16 clinics. You are the most qualified people to give us the list of patients that you strongly recommend that should be given to. So they came with a list of patients, and they were, also committed to make sure the patients receive either by home visits or a call to come to the clinic to pick up the face shields.
Okay. Any other questions? I think it's been very interesting to see the variety of responses around the world. It's because it's affecting so many of us all at once. It's been like an experiment, like where you have different groups, except it's been set up based on governments and all that. And it's been very interesting to see the different responses and to be able to learn from each other. Somebody asked, could you talk about antimicrobial treatment for COVID-19?
Excuse me?
Antimicrobial treatment for COVID-19. How are you guys handling antibiotics and treating bacterial infections for COVID-19?
Well, in Ecuador, there is a protocol defined by the Ministry of Health with the support of the Pan American Health Organization, and they are providing bacterial treatment, and the protocol includes corticosteroids, some antibacterial at the beginning of the disease, and also one which is antiretroviral, that it's being promoted by Pan American Health Organization. But the protocol is only providing, requesting you provide after you conduct some screening with the patient. If they have pneumonia and they have a lack of breathness and the concentration of oxygen is lower than 85%, they are likely to be hospitalized and receive treatment. So people that is receiving treatment is only when it's hospitalized. I don't know if that answered your question.
Yeah, and I think, you know, there's also a lot of concern, at least in the United States, about antimicrobial resistance. And with something like this, with so many people being hospitalized, getting pneumonia, getting treated with antibiotics, in addition to those other medications, are we going to see an increase or complications due to resistance? And so I think that question also makes me think of that. You know, wondering how doctors and hospitals are trying to manage, you know, not just throwing everything at the patient, because we don't actually know everything about this disease yet. We're learning as we go. So yeah, it's hard. It's complicated, and it's we don't know. You know, we just have to see.
Yeah.
Any other questions? Sarah or Paloma, do you have any other comments?
No, thank you so much.
Okay, I don't have any other questions on my end, so I appreciate everybody for coming and being patient with the Zoom rules. And thank you, Dr. Palacios. That was wonderful and very interesting. And like I said, it's, you know, a lot of people in the United States are wondering, what else can we do? And I think that your idea of simply calling patients, it sounds so obvious, but I don't think it's being done, and I think it's a fantastic idea. So thank you for sharing it.
Thank you very much, Rania, and thank you all of you for your patience and interest in learning about COVID in Ecuador. And we will be in touch.
Thank you.
Thank you.
Thank
Have
you.
a good day. Bye-bye.
Bye-bye. Bye-bye. Thank you.
Thank you.